This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs. The Sam and Rose Stein Institute for Research on Aging is committed to advancing lifelong health and well-being through research, professional training, patient care, and community service. As a nonprofit organization at the University of California San Diego School of Medicine, our research and educational outreach activities are made possible by the generosity of private donors. It is our vision that successful aging will be an achievable goal for everyone. To learn more, please visit our website at aging.ucsd.edu.
So thank you all for coming tonight. I'm really honored that you've chosen to spend a little time with me this evening, and especially honored that it's dinner time. So I really appreciate your sacrifice to come listen to me talk for a little bit here. So I am a rheumatologist, so I'm a medical arthritis doctor, but I work within the orthopedics department here at UC San Diego, taking care of people with arthritis and joint pain problems. And we're going to spend some time tonight talking about arthritis, and specifically about osteoarthritis, the most common kind of arthritis. And to begin with, I want to give you a little bit of good news and a little bit of bad news. The good news is by the end of our evening together, you're going to know more about arthritis than most doctors learn in medical school. The bad news is by the end of the evening, you're going to know more than most doctors learn in medical school. Thanks for coming. All right, so it's a time-honored tradition in medicine that if we don't have a cure for something, somebody is happy to sell you a cure for it. It's a great business model. It works. It's really successful. And the reality is, we're working on cures for a lot of things, and there's a lot of great work going on in the buildings around us here doing that. But for most things, we're not there yet. We have good treatments, but we don't have cures. And unfortunately, with the vacuum between everyone wanting and needing a cure and us not having it, there's plenty of people that are happy to sell you that. And these cures can run the range from just being unproven, and maybe they'll turn out to be something great, to being an expensive placebo, or to being just a little exaggerated in how much they're likely to help you, or maybe even sometimes being downright dangerous. And so beware of the snake oil. So it's the 40th anniversary of Saturday Night Live, so I thought we would start with Chevy Chase, an important scientific breakthrough from 1976. Shimmer, the non-dairy floor wax and dessert topping. Okay, and this is kind of something I want you to remember from tonight. Anytime you see a new report in the newspaper, on TV, about a medical breakthrough, I want Chevy Chase's face to pop into your head. And I'm going to explain why. The reason is Shimmer wants to be it all. It wants to be a tasty dessert topping and a practical floor cleaner. And the reality is, it's hard to be both. And things are much more likely to be one or the other. And so with new medical research, that's dessert topping. It's something that's exciting. It's something that gets our taste buds going. We want more. But it's not yet to the point of being practical. Don't try to clean your floors with the dessert topping. It won't turn out well. The dogs will be licking it, and it's not too good. And the same is true with the new medical research. It gets us excited, it gets you excited, but it's not yet ready for prime time, like the not yet ready for prime time players. And be careful about trying to take the new information and equate it with being already very practical. It takes a lot of time and a lot of testing to get things from the new developments to practical everyday use. And so be careful about that. Remember, Chevy Chase's face in your head anytime you see that. Okay. So again, don't expect every new medical report to be both dessert topping and a floor cleaner. Okay? So let's talk about osteoarthritis. It is the most common kind of arthritis. Up to 70% of us may get it at some point in our life. Not all of us. Again, many of us never get arthritis. It's very common in people over the age of 65, probably about half of people. And it's estimated that right now there's 50 million people with doctor-diagnosed arthritis. That doesn't include people who haven't been diagnosed yet. And by 2030, it'll be 67 million of us. It's more common in women than it is in men, unfortunately, like a lot of health problems that I deal with. And it represents almost 2% of healthcare spending in the United States. That's about $65 billion annually. It's a big problem. It's the most common cause of disability in the United States, and it has been for a long time. And if you look at some figures on state-to-state analysis, about 3.5% to 15%, depending upon which state you're looking at, of people in the classic old era working age, under 65, we now know that many of us work well past 65, but many of those folks, again, between 3 and 15%, are working with arthritis. And they're limited in their work by arthritis. And we know that people with arthritis who are matched to other people their age, other similar health conditions, they miss about 4 times as much work as people without arthritis. So it's a big problem in the workplace. And again, it's the biggest cause of disability. If we look at this here, arthritis and degenerative problems in the spine, which is essentially another form of arthritis, are number 1, 2 on the causes of disability. And if we look at diseases that we commonly think of as bad and disabling, heart disease, lung disease, diabetes, you add all 3 of those together, you're not going to add up to either back problems or arthritis, let alone both. So again, this is a big problem. So obviously, we're spending all of our research dollars on arthritis, right? No. So if you look at the graph here, not that spending money on cancer or digestive disorders or women's health is a bad thing, it's a great thing. But if you look at the previous chart of what's most likely to cause disability and look at it in the terms of the percentage of spending on research for arthritis, it seems a little off. And then furthermore, if you look at what those dollars that are being spent for arthritis, most of those are for rheumatoid arthritis, which is a much less common, more serious problem. But again, there's very little money that's being devoted to osteoarthritis research, despite the severity of the problem. So, when you go to your doctor and they diagnose you with osteoarthritis, they tell you that it's degenerative arthritis or that it's wear and tear arthritis. And that's actually not true. And it's right there in the name of the arthritis. The arthritis is called osteoarthritis. Literally, that means bony arthritis. That's not to be confused with osteoporosis, which means thin bones. They both share the Greek word osteon, meaning bone. But what's going on with arthritis, and we're going to talk about this in some detail, is as the cartilage is being broken down, new bone is being formed. This new bone may be called bone spurs. The medical name is osteophytes. It's not actually a little speck of bone. It's actually an increased rim of bone that is growing around the joint. And so in osteoarthritis, the bones are actually getting bigger. Now, if we think of things that wear out, how many things get bigger as they wear out? They don't. Yeah, exactly. When you wear something out, you're literally losing mass. And so just the very name of osteoarthritis tells us it's not just wear and tear. Something's going on that's making the bone bigger, not smaller. So again, this is not a gradual wearing out of the joint by overusing it. It's not a gradual wearing out of the joint by getting older. And again, it's a complicated process. There is a big biochemical process going on here that is breaking down the cartilage and building up bone. We're going to talk again in a little detail about what's going on and why, and it's important to understand that. If we look at a genetic level and look at what genes are being expressed in joint tissue in patients with osteoarthritis, in patients with rheumatoid arthritis, and in people without arthritis, osteoarthritis is 90% like rheumatoid arthritis. It's a lot more like the active autoimmune disease that's destroying the joints. Now, osteoarthritis is not an autoimmune disease, but many of the same genes are active. Again, that's not a wear and tear process. This is an active, genetically driven process that's happening in the joint. And it's very different than what goes on in a normal joint. So why does it all begin? Well, like many things in life, it all starts with stress. And it really is a good way to think about osteoarthritis. There's a quote here from my colleagues in the rheumatology department, Dr. Turkeltaub here, that says that osteoarthritis may reflect a frustrated and ultimately futile process trying to repair stressed articular cartilage. And so what that means is that the joint is able to sense stress, and it reacts to that stress in a way that it thinks will make things better. Now, how many of us, when we're stressed, have done something that we later regret? Yeah. That's what's going on here, is the joint is trying to respond to stress, it's trying to do what it can. It doesn't work out very well in the end. So again, it's not the stress itself that's doing it here, it's the response to the stress. And that stress, I'm not talking emotional stress, I'm talking mechanical stress, I'm talking inflammation stress, I'm talking oxidative stress from free oxygen radicals, and some of this can be genetically predetermined. So in cartilage, there are cells called chondrocytes. And cartilage is a place that doesn't have a blood supply. There are no blood vessels in cartilage. There are no nerves in cartilage. There's not much oxygen in cartilage. And chondrocytes like it that way. That makes them happy when things are that way. And so normally they're responsible for just keeping things the same. It's called homeostasis. They want to keep the balance, a little routine maintenance, just kind of keep things low key and not much going on. But chondrocytes are able to sense mechanical pressure. And if there is too much mechanical stress, they may react to that stress. And again, in some patients, maybe because of genetic factors, they overreact to that stress, and the chondrocyte changes. It goes from the maintenance mode to something that's called hypertrophy mode. That literally means growth mode. Again, going back, there's growth going on here. And interestingly, this is kind of similar to what happens when we're teenagers. As our bones are growing, the long bones, this hypertrophy mode is active, and cartilage is broken down, new bone is formed, the bone gets longer, and new cartilage is formed. Unfortunately, we're not teenagers, and we don't make new cartilage. And so, again, things don't work out very well. So this slide is showing us a little bit of the complexity in terms of what's going on. This slide is a few years old, so it's not as complex as what we now know. But this looks a lot like the slides that we put up for rheumatoid arthritis. There is a lot of inflammatory factors going on here. TNF-alpha, IL-1 beta, IL-6, these are all inflammatory factors that we have medicines in rheumatoid arthritis that target these, that can make rheumatoid arthritis better. I'll beat you to the punch of where you're going with that. No, they don't make osteoarthritis better. But they're still involved in what's going on here. There is inflammation. And it's not just in the cartilage. It's not just in the bone. It is in the lining of the joint, the synovial membrane. There are cells going on there that are part of the process. There's fluid being created there. And so it's really the entire joint that's dysfunctional in arthritis. The cartilage, the bone, the lining, the muscles, it's all involved in the process. And so you might ask, why is it more common as we get older? And the quick answer is we don't entirely know, but we've got some leading suspects. Again, this is not an expected part of aging. This is not a normal part of aging. It's just a common association with aging. It gets more prevalent as we get older. But these days, I'm seeing a lot of arthritis in patients in their 20s and 30s. And that's largely because A lot of kids are playing sports in their teenage years, blow out a knee or have a bad injury to a hip or in a car wreck or something, and injury can lead to arthritis 10 years later. Or we got a little problem with obesity in teenagers, and that can be a big factor as well. So this happens to younger people too, and it can be a big problem. But as we get older, there are changes that are accumulating in our DNA and in the way we express our DNA and the way we regulate its production that change what happens. And these accumulated changes in the DNA and the processing part may be what's responsible for what's going on in osteoarthritis and why it gets more common with age. We know if we take tissue from people who've had knee surgery at a young age, in their 20s, and compare it to people who've had knee surgery in their 70s. And again, look at what genes are being expressed. If we look at the people in their 20s, the genes that are being expressed are often repair stuff, things that are involved in repairing damaged tissue. Unfortunately, if we look at that same tissue in a 70-year-old, the genes that are active are stress response genes, inflammation. So it's again this overreaction thing. And something between 20 and 70 has changed, that the body is now more likely to react, not in a constructive repair way, but in a panic mode that increases inflammation and leads to problems. And again, that's something that's called the senescence-associated secretory phenotype. I don't expect you to remember that. I barely do. But what happens, again, is this increased likelihood as cells get older to react in an inflammatory way to a stimulus. And this inflammatory way, again, ends up breaking down cartilage and building up bone. So again, we look at another slide that depicts the complicated things that are going on here, is that something happens that's stressing out the cell, and that cell switches from the normal maintenance mode to what's called the hypertrophy mode. And some of the cells die. That's what apoptosis is. It increases calcification in the bone, but also in the cartilage too. You can get calcification in the cartilage. Osteophyte formation, again, that's the bone spurs, the bony growth that happens with arthritis. And there are inflammation chemicals involved, something called NF-kappa B, which regulates inflammatory cytokines. We see that a lot in diseases like rheumatoid arthritis, like gout, other very inflammatory process. But again, it's an important part of osteoarthritis as well, especially in the early disease. All right, time for a quiz. We got two x-rays up here. The one on the far side over here, and this one over here. And what I'll call your attention to is that on the near side to me here, in the left knee, notice the space between the bones is not very much. Okay, that person has lost a lot of cartilage. Compare that to the one on the other side where there's great space between the bones. So, which of these two persons is hurting more?
The one on the right.
Yeah. Okay, and which of these persons is more disabled?
I don't know.
Okay, so you've fallen into my trap. Clearly, if I'm asking you this question, it's a trick question, okay? There's test-taking skills involved here. The answer is, I don't know. And that's the honest truth. There have been dozens of studies that have taken people and just looked at x-rays and then asked the patients to rate their pain and tried to correlate the pain scores on a scale from 1 to 10 to how bad the x-ray arthritis looks. There's no statistical significance between the pain scores and the severity of arthritis on x-ray. Kind of weird. But it's really important to understand that. The flip side is good news, is that actually this person with the bad-looking x-ray may have no pain. And that's really part of our goal in the discussion tonight, is to realize that that's possible and what you may be able to do to be that person. We're going to talk about that. But again, there's this big disconnect between the severity of arthritis on x-ray and the pain and function a person is having. I can say the same thing about the ability to walk and function as I can about pain. There's no correlation with damage on an x-ray. So, arthritis pain is obviously very complicated. It's not as simple as we thought. It's not just wear or tear or degenerative problems that are creating the pain. The pain is much more complicated. And again, I've said people can have severe arthritis and no pain, or people can have very little arthritis and have severe pain. It goes both ways. And so, how bad the picture looks. People often come and ask me, let's get a picture to see how bad it is. Let's get an x-ray to see how bad it is. And sometimes that's important. But what's more important to me is how well a person is functioning. That's what tells me how bad the arthritis is, not just how bad it looks on an x-ray. So again, I've already said cartilage is a lonely place, kind of like the desert here. No blood supply, no oxygen, but again, no nerve endings. So you can lose cartilage and not feel it because there are no nerve endings in cartilage. So many people, especially in the early stages of arthritis, don't know they have it because they're not feeling any pain. And again, this is normal and expected. Or in kind of the medium stages of arthritis, the pain is episodic. It will come and go. One day you'll have pain, or maybe for a few weeks, and it will go away, maybe go away for 6 months and then come back again. That's very normal. Doesn't mean the arthritis is suddenly getting worse. It means the pain is getting worse. And again, we'll talk about why. So people in this early and middle stage come to me, and usually they say, I hurt myself, because something happened and the pain suddenly came on or suddenly got a lot worse. And usually the something was doing a little too much. Maybe it was spending all day at Disneyland, maybe it was cleaning out the garage, but something that was a little different from the normal routine. But what I try to do is to hone in a little bit more carefully on the story, because usually the story is more like this. Yeah, I was working in the garage all day and yeah, my knee was bothering me a little bit, but that night or the next morning, it was killing me and I couldn't walk. So it's usually sometime afterwards, maybe 4 hours later, maybe 12 hours later, that things get really bad. Now, if you watch the Chargers on TV and you see my colleagues in the orthopedics department going out to assist one of the Chargers who's gotten hurt on the field, if you tear your ACL or if you suddenly tear your meniscus, you go down instantly. You don't complain about it 4 hours or 12 hours later. That's not what happens when you get an acute injury. It is instantaneous, the pain is severe, you can't walk immediately. Those are injuries. The other stuff is much more likely to be osteoarthritis as to what's going on. Now, one of the important things, other than Chevy Chase's face, that I want you to walk away with tonight is to realize that pain is not a sign that you're causing damage. It's a common misconception. It's human nature. If something hurts, I'm damaging myself, I need to stop. It's human nature if you see a cake to eat it. But if you have diabetes, it causes a problem. It's human nature if you have pain to stop. If you have arthritis, it causes a problem. Be careful about human nature. So pain is not usually a sign that you're causing damage. Pain is really a sign of unhappiness. Your joint is complaining to you, but it doesn't mean that it's being injured. It just means that it's unhappy. Now, after you have indulged listening to me for an hour and a half tonight, those of you with arthritis will get up and your knees or your hips will complain. Is it because you have damaged them when you first stood up? No. They're complaining because you haven't been using them for the last hour and a half. That's what they're complaining about. That's why people often have more trouble in the morning when they first get up. Again, you've been inactive for a long period of time, or you've taken a long car trip. Again, it's the inactivity that the joints are complaining about. All right, so those of you who are trying to be one step ahead of me, I've already told you that x-rays don't correlate with pain, they don't correlate with function, so you're already ready to ask for the MRI. And the MRI does give us some information that's important to me in understanding the arthritis. Unfortunately, it may be a little dangerous for you as the patient, and I'll explain why. So interestingly enough, again, if we look at an MRI, we can see cartilage very well on an MRI. We couldn't see it on the x-ray, it just looked like an empty space. but we can see it on an MRI and we can actually quantify how much cartilage is there. The amount of cartilage on an MRI does not correlate with pain or disability. Whether you have a torn meniscus doesn't correlate with pain or disability. Whether you have an extruded meniscus doesn't correlate with pain or disability. Whether you have big bone spurs or no bone spurs doesn't correlate with pain or disability. But there are two things on an MRI that do correlate with pain or disability, and they tell us something. They tell us about what is most likely causing the pain in people with arthritis. Again, not the structural damage. Those don't correlate. But two things that are associated with inflammation in the joint. Number 2 on the list is swelling of the joint or swollen joint tissue, called synovitis. If you have an unhappy lining of the joint, it's reacting to stress, it gets inflamed. It secretes chemicals that promote inflammation, and that inflammation may lead to swelling of the joint, fluid, or it may lead to pockets of swollen joint tissue, synovitis. And both of those things are correlated with pain. But again, they're a reaction by the lining of the joint to stress. In the bone itself, we can see what's called bone marrow edema, or bone marrow lesions is really the preferred term, but most of the time you're going to hear bone marrow edema. And that's typically above or below the area of cartilage thinning. And that is very tightly associated with pain. And it may also be associated with disease progression in terms of the arthritis getting worse. That's less clear, but it clearly is associated with pain. And again, what this represents is unhappy bone. The bone is stressed, it gets inflamed, and then it becomes painful. So how do these areas get inflamed and cause pain? Again, it comes back to stress. So we already talked about arthritis itself being an overreaction to stress. But the episodes of severe pain are also an overreaction to stress. And so what happens? Again, the joint and the cells in the joint are able to detect change. And they react to this change. And they go into panic mode. And that panic mode, again, is the inflammation, and that is what leads to pain. So again, when you have arthritis, the enemy really is change. It is suddenly doing something that you're not used to doing. The joint may overreact to that. Or suddenly doing less than you're used to doing, and the joint may react to that too. Or worse of all, overdoing it and then spending the next 2 days in bed. Okay? Think about your car at 60 miles an hour. Driving 60 miles an hour, staying at 60 miles an hour, that's not a problem. Suddenly going to 0 is. Okay? And your body's kind of the same way. If you're going 60 miles an hour one day and 0 the next day, that's incredibly stressful for the joint, and it reacts to that. And that's where you get the inflammation. That's why you get the swelling. That's where the inflammation in the bone marrow edema comes from, and that's why you get pain. So again, it's telling us something. The MRI does give us some important information about what you can do to prevent those episodes. Change is the enemy. But unfortunately, if we take anybody over the age of, 18, and put them in an MRI scanner, we're going to find problems. Guaranteed. And that's where the art of medicine comes in, is we don't treat x-rays, we don't treat MRIs, we treat people. And so the key for me is putting together the story, the exam, and what we find on the MRI. And again, we get too much information from the MRI. We get things that are anatomically wrong, but aren't bothering people. And we can take people with no symptoms at all, put them in the MRI scanner, we're going to find problems in their knees and hip. Guaranteed. But again, just because we find them there doesn't mean that they're the source of the pain. Now, unfortunately, radiologists, when they write their reports on the MRI, are taught to be structured. The way you avoid missing something is to follow a set pattern every time you do something. And so when a radiologist interprets an MRI of the knee, guaranteed, the first thing they're going to mention is the meniscus, because that's the pattern that they're taught to do it. That doesn't mean that the meniscus is the most important finding on the MRI. It's just the way they discuss things. Almost everyone with more than just mild arthritis is going to have a torn meniscus. And so you show me a person with arthritis, I'm going to predict on the MRI you're going to see a torn meniscus. But most of the time, the meniscus is not the problem. Again, remember what's going on here is the joint is reacting and it's secreting chemicals that are breaking down cartilage. The meniscus is an extra piece of cartilage that is in between the joint cartilage. And those same chemicals break down the meniscal cartilage as well. And so it tends to develop tears in it over time from those chemicals. Or, if you remember what I said before, people who get injuries can later develop arthritis. So a torn meniscus can lead to arthritis later on. But once you get significant arthritis, it's really the loss of cartilage overall that's the problem. And it's not the tear in meniscus that's causing the pain most of the time. Now, there are exceptions. If the knee is locking because of a torn meniscus, that may be the issue. But we also have a number of studies to say that in people who have arthritis and have a torn meniscus, if you go in arthroscopically and try to clean up the meniscus, it doesn't work. That if you look a year later at people with arthritis who've had arthroscopic surgery for a torn meniscus, or people with arthritis who didn't have the arthroscopic surgery, at a year, there's no difference between them. The other thing to keep in mind is what's going on at arthroscopic surgery with a torn meniscus. They don't repair the meniscus because, again, the meniscus for the most part doesn't have a blood supply, so you can't sew it together. There's a portion of it that does, but that's not usually where the problem is. So what they're doing is trimming up the loose ends to try to make it less likely to catch. If it's locking, that works great. But if the problem is you don't have enough cartilage to begin with, and you start taking out cartilage, this is first grade math. So, beware. So another big problem we're facing is getting bigger. And obesity is a skyrocketing problem in all parts of the world, in kids. And again, it is a major risk factor for arthritis. And so we're expecting a big increase in the amount of arthritis over the next number of years because of the fact that we're bigger as a society. So the standard thinking is that this is due to the weight of the weight, that you're putting too much stress on the knee because of the weight, and that's what's causing the problem. And that clearly is part of the problem, but it's more complicated than that. So weight does increase stress on the joint. We've already talked about stress being a problem here. But it also changes the way you walk. When you're massively overweight, the gait pattern changes from being mainly about moving forward to being more about balance. And so it changes the way you're distributing the forces in the knee, and it actually, again, increases the stress because of that. But it's worse than that. There are chemicals in fatty tissue, and one in particular that we have some evidence of is something called leptin. Leptin is a pro-inflammatory molecule. It may have some role in heart disease. It may have some role in risk of breast cancer, but it may have some role in arthritis as well. We know that if you take fluid out of someone's knee and with arthritis and measure the leptin level, the higher the leptin level in general, the worse the arthritis, and the more likely the arthritis is to get worse. Now again, I know you're thinking, well, the bigger you are, the more leptin you make. It's true unrelated, that it's just the weight of the weight that's causing the problems. Here's where things get interesting. There are a couple of studies in people with arthritis in their hands that show that the leptin levels in their blood predict how rapidly the arthritis is going to get worse. The higher the leptin level, the more rapidly the arthritis gets worse. Unless you're a circus performer, you're not walking on your hands. So it's not the weight of the weight that's the issue. It's, again, this pro-inflammatory effect of fatty tissue that may be driving the arthritis process. And again, we've already talked about that arthritis is a big issue in terms of disability and lost work productivity. But most people don't think of osteoarthritis as something that shortens your life. You don't drop dead from arthritis. What are people most likely to die from? Unfortunately, it's heart disease. Now, but many people with chronic diseases also have arthritis, and it's roughly about 50%. So people with heart disease, about half of them have arthritis. People with diabetes, about half of them have arthritis. People with chronic kidney disease, about half of them have arthritis. Now, if you have high blood pressure, if you have heart problems, if you have diabetes, what does your doctor tell you to do to get better? Exercise. But if you have arthritis, that can be an obstacle to exercising. So people with other chronic health problems and arthritis don't do as well. And on average, are more likely to die sooner than people without arthritis. And again, predominantly because it makes them less active. That seems to be the linking factor, is if you have arthritis that limits your ability to walk, it increases your chances of getting strokes and heart attacks. So not walking is not good. All right. So this is my favorite quote of all time because it applies to just about everything in life, including osteoarthritis. So, y'all like to complete this for me? So true. So true. And again, I've bored you to death with x-rays are not correlated with pain and are not correlated with function. But fear is. So if someone is afraid that they're going to hurt themselves by using a joint, they're much more likely to have high pain scores, and they're much more likely to be disabled. So fear is more likely to disable you than bad arthritis. So again, you have nothing to fear but fear itself. And again, I've already told you, pain is not a sign you're causing damage. So yes, it may hurt, but it doesn't mean that you're damaging the joint. And in fact, the worst thing you can do to a joint with arthritis that's hurting is to stop using it. That makes things worse rather than better. But it's more complicated than that. So traditionally, we have thought of arthritis as mechanical pain. And again, I've already talked a lot about that's not really true, that it's part of it, but it's not all of the big picture. But we've also realized that a big part of pain involves the nervous system and the way pain signals are processed. And something that we call sensitization. It can happen in the peripheral nerves, it's called peripheral sensitization, and that's very common in arthritis. It can also happen in the central nervous system, in the spinal cord and in the brain. That's also very common with arthritis. And so people with arthritis, because they're in pain very frequently, the nervous system kind of gets overly stimulated. And again, overreacts, common theme, sets up kind of a vicious pain cycle, and it becomes overly sensitized, and so now even less stimulation leads to pain. And also more nerve endings are recruited to be part of the pain monitoring apparatus, and so the area of the pain gets bigger over time. And again, these things are happening in and around the spinal cord. So there's another disorder that I frequently see called fibromyalgia, and that's a widespread pain problem that we've known for a long time is caused by an oversensitivity of the nervous system. But even in people with osteoarthritis, or for that matter rheumatoid arthritis or anything else that hurts, a certain percentage of them are going to develop very similar hypersensitivity or central sensitization that people with fibromyalgia get. It's just localized. It may be just in and around the knee or hip or the joint that's affected. But it's a very similar process. And again, it can be aggravated by a number of things: not sleeping well, emotional stress, fear, we've talked about that, depression, or decreased or inconsistent physical activity. Now, interestingly enough, this sensitization in people with arthritis, if people have a joint replacement and their pain gets better, the central sensitization seems to go away in most of those individuals. So it's reversible. And the nervous system is often very plastic. It doesn't necessarily stay the way it is. So again, it's an important lesson to know that things are not necessarily have to stay that way. They can be better. So a lot of what little research dollars are being spent are looking at hopefully developing what's called disease-modifying osteoarthritis drugs. We have those drugs for rheumatoid arthritis. They're called DMARDs. And in the 20 years that I've been a rheumatologist have dramatically altered our ability to treat rheumatoid arthritis. We've gone from 5% of people doing well and 95% of people doing bad to the other way around because of those great drugs. Still not perfect. We got a long ways to go, but infinitely better. We're not there with osteoarthritis. We don't yet have drugs that really modify the course of disease. There are a few studies that have shown some really modest benefits. There are 3 or 4 studies that have shown a little bit of improvement in the space on x-rays. So that space where cartilage sits gets a little bigger after taking these drugs for 2 years, suggesting that cartilage is getting more. But people aren't feeling any better. And so again, there's this disconnect. And furthermore, we're not entirely sure if the difference that we're seeing on x-rays or even on MRI, where maybe we are seeing thickened cartilage, if it's really effective cartilage. It may be a different kind of cartilage called fibrous cartilage that doesn't work as well as the cartilage that you're born with. So again, trials to develop drugs to change the course of arthritis have thus far been disappointing. Doesn't mean we've given up on it. We're still working on it. And again, understanding a lot of the biochemistry that we talked about here gives us opportunities that we may be able to act on as time goes by. But we're not there yet. So coming back to filling the void of not having a cure. There are things that are available and routinely done that are really early in our understanding process, but are kind of a little ahead of the track in terms of being available for everyone to use without really knowing all that we need to know about them. And one of these agents is something called PRP, or platelet-rich plasma. And I've got Tiger Woods' picture up here because Tiger's had these injections. A lot of athletes have had them done. And a lot of people have reported that they've really helped them. And this is a study, not that I'm going to quote here, not from a disreputable place. This is from the #1 ranked orthopedics program in the United States. This is from the Hospital of Special Surgery in New York. And this is quotes directly from their website that PRP injections hold great promise for treating patients with knee osteoarthritis, that a study that they did improved pain and function, and up to 73% of patients appeared to delay progression of osteoarthritis. Wow, that sounds really good. I want some of that. But wait, there's more. We're entering into an era of biologic treatment, like I talked about, the holy grail that we've been searching for, which is incredibly ideal, where you can use your own cells to try to help repair your other cells rather than using a substance that's artificial. The downside is next to zero and the upside is huge. Again, definitely sign me up for that. But, thank you. The devil's in the details. And the key for us in an academic situation is to really look at the study itself. And, okay, how did they come to these conclusions? What is the science and the data that led them to say, hey, this stuff is amazing? Okay, so 22 patients. That's it. That's a very small number and hard to base earth-shattering, revolutionary conclusions that we've now got this miraculous treatment on 22 patients. Because we've been there and done that with about a gazillion things before. Didn't pan out when we looked at 500 or 1,000 patients. Number 2, who are they looking at? They specifically limited the study to people with very mild arthritis. Okay, so I've already told you, people with very mild arthritis oftentimes have no symptoms. Or if they do have symptoms, they're of short duration and then they get better for long stretches of time. So they take someone that the normal history of the arthritis is you're going to be symptomatic, and that's when you're seeing the doctor. They give them a medicine and they get better. Well, again, I've already told you the expected situation in someone with mild arthritis is they're going to get better anyway. So the fact that they felt better doesn't really tell me much. Okay, I would have expected that if you had just waved your hands over them and said, boo. It's what I expect from mild arthritis. Number 3, there's no control group. Okay, so there's no comparison. They don't compare the people who got the PRP injections to someone who got a placebo. So did they do better than other people? I don't know. They didn't test other people. So But the thing they were most impressed with is the MRI didn't get worse over a year in about 3/4 of the patients. About 1/4 it did get worse. That's what I expect in early osteoarthritis. Osteoarthritis doesn't inevitably get worse with time. And for many people, it plateaus for long stretches of time. And especially in early disease, I don't expect it to get worse over a year. Now, what they didn't comment on is, I think the true value of this study is that, at least in a very small number of patients, they didn't document that people got a lot worse over that period of time. So it didn't appear to be harmful in that small group. And they got the MRI data to show that. That, I think, is good information. It's not what they were excited about, but it's what I take from their study. So again, it's hard to get too excited about those results, and that we need to know more. And so again, report in the media. What are you guys supposed to think about? Chevy Chase. This is dessert topping. This is not floor cleaner. So it's not yet practical. It's stimulating, it's interesting, and it bears further study and further research, but it's not yet ready for prime time. This data doesn't convince me in any way, shape, or form that it's ready for prime time. Now, there is a little bit of information that PRP may be helpful. And this study is probably not the best one, although again, it's one that I've actually had some of my colleagues in orthopedics training, they hear quoted at meetings as being a great reason to use PRP injections. It's not. There are some better studies, but again, the best of them is only about 70 patients that suggest that it's better than placebo. So, and those studies don't have any long-term follow-up information to suggest that it's safe. And so really, we're really very early in the information. And so again, dessert topping. We're not, maybe it'll turn out to be great, but maybe not. So another area of exciting research is stem cells. And stem cells get us all excited. Stem cells have the potential to be anything. And they may offer a lot of very successful treatments and may get us at some point to those cures that we're searching for. But there are buts. So that's the bad thing about stem cells too, is they have the potential to become anything. And so stem cells that are typically used for joint issues are called mesenchymal stem cells. They come from fatty tissue. They could come from bone marrow or fetal cord tissue, but again, most commonly from fatty tissue. So you can combine a liposuction with a joint injection. It's a win-win situation. Okay. But what tells a stem cell what to become? It's its environment. So stem cells react to stimulations that they get that say, okay, this is the need that's going on in the environment I'm in. This is what I'm going to become. So what might be likely to happen if you take stem cells and put them into a bad neighborhood? They go to the dark side. Yep. So it's something to be careful about. And again, in a lot of areas of research, stem cell use has been disappointing, but there's still a lot of good investigations going on. One of the areas I think is promising is in animal models where they're using stem cells in scaffolds. They take a scaffold that is designed to hold cartilage in place, and they put chemicals within the scaffold that promotes stem cells to become what we want them to become, cartilage. And that may be promising. It's still very early in development. That ultimately may be a great use to stem cells. But we're not there yet. And one recent study that I saw at our national meeting this fall from the University of Michigan looked at people who were getting hip replacement. So these are people who weren't doing well. They had surgery. They got MRIs on them before the hip replacement, and then they looked at the tissue after the hip replacement. And what they found is in the areas on the MRI that had the bone marrow edema, again, the areas that are inflamed, that are associated with pain, they were chock full of stem cells. So these patients who were not doing well and had to have their hip replaced already had lots of stem cells in the area that was causing the pain. Now, you can look at that two ways, and neither of them look good in my viewpoint. One is that the stem cells were trying to respond to a problem and failed. The other one is that they were the problem. I don't know. I honestly don't know. But again, it gives you pause for thought when you're thinking about stem cells. So again, dessert topping, Chevy Chase. So Stem cells are not yet ready for prime time. They're exciting. They may turn out to be something revolutionary, but we're not there yet. And as an example of things that look really good up until the point we get them in large numbers of people is a medication called tanezumab, which is an antibody against nerve growth factor. And there were some studies done in 2008 to 2010 that were wow. And I do mean wow. I mean better than anything we had ever looked at in terms of relieving pain with osteoarthritis. And in a phase 2 study, decent number of patients, it was a 45 to 62% improvement of pain compared to 22% in placebo. And that's good. Then they got to the phase 3 trials where they expanded to even larger groups of people. And during that trial, they realized that a number of patients that were in the treatment arm were suddenly getting a lot worse. And the study was stopped by the FDA and was actually held for several years. They were reopened for a little while and then closed again. It's an ongoing issue. But what probably appears to have happened is that many people got better and good pain relief. Some people got a lot worse and had to have an immediate joint replacement. So it was kind of flipping a coin. Either you got better or you got worse. But we didn't see those safety signals in the smaller groups. So even in several hundred patients in the phase 2 trial, we didn't see that. It wasn't until a study of almost 500 patients that this was seen. So you have to be careful about small studies and not knowing really if they are ultimately going to be safe over time, because you may not see the safety problems until you get large groups of people. Another potential issue with both PRP and stem cells is that they're home brew. Okay, these are prepared from your own blood, at least the ones that are available for use now, not necessarily the ones in the research studies. They may have a different source. But again, so you donate blood. They take about 80 cc's out or 60 cc's out. They spin it down in a centrifuge for the PRP, or they isolate the stem cells by other techniques, flow cytometry and other things. And then they give them back to you. But that's the first word of caution. They're giving you your own cells back. These are the same guys that led you down the bad road to begin with. So it's kind of like giving the keys to the bank robber and say, okay, you take care of the place now. I don't know if you want to do that. Number 2 is no one agrees on the recipe. So there are many different ways to make it. And so from one office to another office, one machine to another machine, they're all a little different. And we have some information to say that those differences can be very meaningful in terms of their effectiveness, or maybe in terms of having stuff you don't want in there that could cause problems. And unfortunately, we don't yet have taste tests comparing recipes. The third thing is these products are not regulated by the FDA. Again, these are your own cells that are being taken from you and given back to you, so there's no regulation process. It's just you. And so there really aren't the studies and safeguards that would be in place for something that is being carefully studied and monitored, and again, looking for those safety signals like we saw in the anti-nerve growth factor. Those aren't being looked for. So there was also a really interesting study that, again, did get in the media recently, so please think Chevy Chase. It was a very small study, but it's still, it still tastes good to me. It's still intellectually stimulating, so I think it's worth at least talking about. And they took people with Parkinson's disease, and they grouped them into 2 groups. One group, they gave them medicine, and they told them that this is, we think, going to retail for about $100 when we get through the trials if it works. And the other group, they gave them a medicine and they told them, we think it's going to retail for about $1,500 a treatment when we get through. Guess what happened? The expensive one worked better. So expensive placebos are better than cheap placebos, and at least in a small study, we have the evidence to prove it. Our brains are wonderful and unique things, and they can do a lot of good things and a lot of bad things. And so they can lead us down the wrong road, but they can also do a lot of good things to help us get better too. But again, so Beware the expensive placebo. So despite all the kind of naysaying that I've done for the last 10, 15 minutes here, there is such a thing as treating osteoarthritis. And let's go back to those x-rays, the quiz that y'all failed earlier. We're not able to make the cartilage look better, for the most part, except for a few studies that, honestly, we laugh at. But it doesn't matter as much as you might think. And that's the important thing to walk away. So you don't have to make the cartilage look better to feel better. There's that disconnect, and we can use it to your favor, not to your detriment. So if it was solely about making the x-rays look better, you'd be screwed, because we can't. But it's not, and that's important to know. And we have lots of things that are able to improve pain, that are able to improve function, and able to improve quality of life. And who couldn't use a little better quality of life? All right. So number 1 on the list, number 2, number 3, and probably number 64 is exercise. And we have literally thousands of studies to say that no, exercise is not harmful. It doesn't cause damage. It doesn't make the arthritis worse over time. It makes things better. It makes the pain better. It makes function better. It makes quality of life better. And unlike studies with pills, if we look at anti-inflammatory medications or pain medications, the benefits in those studies seem to be pretty short-lived. People get better for 3 months, maybe 6 months. If we look out at 12 months, a lot of those folks have dropped off and the benefits have fallen. That's not true with exercise. If you continue to exercise, the benefits are generally continued. A lot of people ask me, what's the best exercise? And I have a pretty standard response to it. It's the one you're willing to do. So if you try to fit a square peg in a round hole, you're going to fail. If you try to do an exercise that you've read about as the best exercise and you can't do it or you don't like it, you're going to fail. And so the best exercise is the one that you can fit into your life. And most importantly, that you can do consistently. Let's go back to that stress model that we talked about earlier, okay? What creates the pain? What is a factor in causing the arthritis? Stress. What creates the stress? Change. So again, the goal with exercise is limiting change. It is trying to develop a consistent routine. Now, if you're an athlete or a former athlete, you're not used to 7-day-a-week exercise. If you're trying to build muscle mass and strength, exercising 3 days a week intensely is a good way to do that. It doesn't work for people with arthritis. Again, car at 60 miles an hour, car hitting a brick wall. Not good. With arthritis, the exercise needs to be different than what you do for strength or endurance training. It needs to be a consistent 7-day-a-week routine. Your joint needs to get used to doing that. And then when it gets used to it, it doesn't get stressed by it. It doesn't react to it. It doesn't lead to the inflammatory changes that are associated with pain and maybe even progression of the arthritis. So consistency is good. Any kind of exercise is good. And again, it could be walking, it could be bicycling, it could be in the water, it could be Tai Chi. We have many dozens of studies to show that Tai Chi is beneficial for people with arthritis, chronic back pain, balance disturbance, many things, and is a good way to start. So, but the key is to start small, a little bit every day, and do it consistently and gradually increase it. If you've bitten off a little more you can chew, don't stop. Again, 60 miles an hour hitting a brick wall. Ease up a little bit. So again, if you're driving down the road at 60 miles an hour, you see a police officer, don't slam on the brakes. It's calling attention to yourself, you're going to get a ticket. You want to take your foot off the gas and gradually ease on the brake. Same thing when when your knee is putting on the red siren, you want to ease off just a little bit. Vary it just a little bit, but don't stop. So try not to make major changes in the routine. And people are always looking for a natural way to treat arthritis and to treat any disease. And I think that's great. Exercise is perfectly natural. So is cyanide and arsenic, but we won't go there. But it really is. And again, we've got so much information that it's good for arthritis. We get so much information that it's good for just about everything. It's good for dementia. It's good for heart disease. It's good for diabetes. It really is. People are looking for this magic pill. We kind of already have it. We just don't want to recognize the 800-pound gorilla that's trying to make us exercise. But it really is kind of magic if you can start small and be consistent. And again, try to limit the change. And the effects of exercise are really very complicated physiologically. It's not just the joints you're using. It changes, remember we talked about the sensitivity of the nervous system? It changes that. Consistent exercise improves that. It gets rid of that sensitization. It has direct effects on the brain, on mood, on pain processing. It's really very complicated. We also talked about weight loss, and that, or we talked about weight gain. Now we'll talk about weight loss. And we know that it's an important thing too, and we have, again, a lot of studies to say that people who lose weight do better. And the magic number seems to be about 10%. So a lot of times people get in mind that they have to get skinny to feel better when they're overweight with arthritis, and that's not true. You can generally take where you're at and set a goal of 10% less than that. So if you're 250 pounds, that's 25 pounds. That's reasonably achievable. It's not as high a bar that you're going to try to get to and fail. It's something that's more likely to help. There was a really interesting study out of Duke that took people who were overweight with arthritis and put them on a treadmill. And they fitted them with an airtight device similar to what you would use in a kayak in cold water to keep the cold water from getting in. And they inflated air underneath to literally buoy the person up so that they weighed less. And they found that at about 10% reduction in weight because of this pressure of the air, people's pain got a lot better on the treadmill. But we also have a number of studies to say that in people who do lose 10% of their weight, their pain scores get better, their function gets better. So 10% is kind of a good number to shoot for. We also have evidence to say that in people with arthritis who lose weight, 11 pounds in one study that comes to mind, on average, in a big population study, they were 50% less likely to get a new diagnosis of arthritis during that time, so develop arthritis in another joint and get it diagnosed, as opposed to people who gained weight who are more likely to get a diagnosis of arthritis. So it may reduce the frequency of developing arthritis if you're able to lose weight, or at least developing arthritis that causes you to go to the doctor. Unfortunately, losing weight doesn't seem to make the x-rays better. And they don't seem to alter the progression on the x-rays. So the x-rays may or may not get worse with time. Not everybody with arthritis, the x-rays progress. Some they do, some they don't. But in people who lose weight, their x-rays get worse at the same rate as people who don't lose weight. So it seems like the cow is already out of the barn, and that losing weight doesn't alter the progression of the cartilage loss. But again, we've already said that's not as important as we might think. And so again, even so the people who do lose weight have improved function, improved pain, even if the pictures don't look as pretty. So picture's getting worse, feeling better. It's not as crazy as it sounds. So anything else that you or I do is not a treatment for the arthritis. The treatment is exercise. The treatment is weight loss. Anything else that we do is a tool to help you exercise and lose weight. And that's the best way to think about other stuff. So traditionally, you go to your doctor, you complain of arthritis. The standard answer is take 2 aspirin, take 2 ibuprofen, take 2 naproxen, and never call me about this again. That's kind of the standard response. And really, we are shifting away from using pills for arthritis for 2 reasons. Number 1, they don't work that well. Number 2, they're a lot more dangerous than we thought. And specifically, anti-inflammatory medicines like ibuprofen and naproxen, the risks go up as you get older. Again, the risk for arthritis go up as you get older, and the risk from these medicines go up as you get older. And we've long known about stomach ulcers, and using a full dose of an anti-inflammatory gives you a 1 in 20 chance of a serious side effect. That's a stomach ulcer. 1 in 20. But we also know that they can increase blood pressure. We know that they can worsen kidney function if you have decreased kidney function to begin with, and we don't recommend using them in that setting. And we now know, after Vioxx, that, again, not something that was seen in the early trials, something we didn't see until they were on the market for a long time. And Vioxx worked too, in large part because it acted on the central nervous system part of pain, but we didn't go into that story today. But Vioxx increased risk of heart attacks and strokes, but that's what led it to go off the market. But all anti-inflammatory medicines can increase the risk of heart attacks and strokes. And specifically, it seems to be in the first 6 months of starting them. It's not a long-term side effect like many things are. It's in the early days of using them that people seem to have the most risks. And so as a result of all these things, generally, I try to avoid those medicines if I can. They're really last resorts. So when it hit the fan with Vioxx, everybody rushed to opiate medications, and myself to some degree included. And what we found with that is that people had actually an increased risk of dying with arthritis and taking opiate medications, predominantly because of falls, because they dull your sensation and they make you more likely to fall. So again, they have to be used with caution. Also, we had some really interesting studies, Chevy Chase, from the early 90s from Italy that looked like glucosamine was really, really promising. And a lot of us, myself included, as well as the Arthritis Foundation, the American College of Rheumatology, and the European League Against Rheumatism, all kind of jumped on that bandwagon. It's safe, not cheap, it's expensive, but it seemed to help a number of people. Except the follow-up studies really never supported that. And a number of studies have been done that have failed to show benefit. Some might argue that it's the actual component of the medicine itself, and maybe there's some validity to that. I don't know if you saw in the news last week, Chevy Chase, that there was a study done in New York where they took supplements from popular stores and actually looked to see if what was supposed to be in them was in them, and it was about 10% actually had what you thought you were buying. So again, the lack of regulation is a potential problem there. And in the Italian study, it's a pharmaceutical grade medication. But having said that, in studies of pharmaceutical grade glucosamine and chondroitin since then, they've really failed to achieve the benefits that were seen in those two early studies in the 90s. And so now every major organization, the American College of Rheumatology, the European League Against Rheumatism, the Osteoarthritis Research Society International, no longer recommend glucosamine. And in fact, 2 of the 3 specifically recommend against taking glucosamine. Because we've seen some increased risk. It can elevate blood sugars over time. There may be some effects with glaucoma. So they're not as safe as we thought they were either. So generally, again, we're trending away from pills. Topicals are a way of doing it, and sometimes I find they can be very helpful, but again, they're of modest benefit at best. So injections can be a tool, again, not a treatment, but a tool to help people exercise and lose weight, and it's something that I do frequently do. And specifically corticosteroid injections, despite rumors to the contrary, don't really lead to long-term worsening of the arthritis. They're kind of myths that are persistent from steroids from the 50s or from our experience with steroids as pills to say that they're very dangerous. But if you stop drinking water because people drown, that could be a problem. Context and amount matters, and that's true with the injections. And again, we've been doing these for 50 plus years, and as long as we don't give them more than every 3 months, they really do seem to be safe. The risk of a serious side effect is 1 in 30,000. Again, let's compare that to over-the-counter ibuprofen and Aleve, 1 in 20. Overall, pretty safe. However, there's a downside. In some joints, they don't work very well. For instance, in the hip, maybe 10 or 15% of the time. They're really disappointing. And they're pretty short in their benefit. The average is about 3 months. The most often they can be given is every 3 months. So it's not providing long-term benefit for folks, and that's disappointing. Which leads us to hyaluronic acid injections. And contrary to the ads that you may read in the newspaper or hear on late night TV or talk radio, these are not new. They've been around for over 15 years. They're not the greatest thing since sliced bread. In fact, some of my colleagues believe they are equivalent to placebo. There are some studies, something called meta-analysis, where they combine studies together that have some similar structure to them. And in those studies, and especially if you include studies from pharmaceutical companies that were never published because they said negative things about the drug they were trying to bring to market, they don't really seem to show much benefit. On the other hand, there's some of us to believe that they are somewhat effective in some people, so they do have their role, and I do use them. But again, they're not the greatest thing since sliced bread, and they're overall not very effective in people with severe arthritis, so they're a lot less effective in that situation. And right there on the product insert, it will tell you that they help cushion and lubricate the joint, except they don't. We've been telling people that for 15 years, and it turns out not to be true. We now know that if you label the medication and inject it, it's gone within 2 weeks. The body has already broken it down, and it's not sticking around in the joint and helping cushion or lubricate. Now, typically, people don't feel better for 2 to 4 weeks after the injections. So it's already gone before people feel better. The main advantage of these medicines is that when they do work, they last longer than cortisone. The average is about 5 to 6 months. Again, it's a very select population that they work for. It's a much smaller group than corticosteroid injections. But for those folks, it can provide longer benefit, and that's really, I think, their calling card. And it turns out, again, the short answer is we don't know how they work at this point, but one of the possible mechanisms that we have some basic science evidence to support is they may actually work through a very similar mechanism as cortisone injections. If you remember one of the slides I threw up earlier, and I'm sure that this stenciled into your brain that you have photographic memory and saw everything on the slide, but one of the chemicals or not chemicals, but gene elements that I mentioned is something called NF-kappa B. That is a pro-inflammatory. It upregulates inflammatory cytokines and is an important factor in lots of inflammation problems, including osteoarthritis. And we know that the predominant way that corticosteroids work is by downregulating NF-kappa B. That's how they do what they do. But interestingly, hyaluronic acid is a damage signal in the body. So the body is able to react to hyaluronic acid. There are receptors for hyaluronic acid. And if you stimulate hyaluronic acid receptors in antigen-presenting cells, a downstream effect is downregulating NF-kappa B. So it may actually be working the same way as cortisone. It just takes longer to get there and lasts longer when it does. We're not sure yet. That's, again, Chevy Chase. All right. So lastly, there is surgery. And a lot of people get in mind that when they get told they have arthritis, it's inevitable that they're going to have surgery. And that's not true. The best way to look at surgery is, again, a tool that's on the shelf that's there if you need it. It's not something that you necessarily have to use. You can walk away from the shelf and never take it off there. Only 1 person in 8 with arthritis in a knee or hip has a joint replacement. 1 in 8. 7 out of 8 don't. Now, I might argue that some of those 7 maybe should, but again, most people don't. So it's not inevitable that you have to have surgery. And again, I've already said the X-ray doesn't correlate with pain or disability. So don't let an X-ray tell you when it's time to have surgery. It shouldn't. Okay, so a lot of people come in, let's get an X-ray to see if I need surgery. No, that's not what X-rays are for. So when is it time to consider surgery? When the arthritis is limiting your ability to be active, limiting your ability to exercise, limiting your ability to do what you want to do, and these other things that we've been talking about: exercise, weight loss, injections, topicals, pills, therapy, whatever, are not doing the job. That's when surgery is a great option. Now, with the hip, that's kind of an exception. And so people with arthritis of the hip that are significantly limited, my ability as a non-surgical arthritis doctor to help them Yeah, it's not very good. And the results tend to be disappointing. On the other hand, the surgery for hip replacement tends to be, wow, and that many people get a very quick benefit, a very easy recovery, and the success rate is very high. It's not perfect. Again, some people do develop complications, so it's not to be done in people who are doing well, because you don't want to be the 1% that gets an infection in their joint. But on the other hand, for people who are significantly limited in their quality of life by a hip problem, I don't hesitate to send 28-year-olds to have a hip replacement because it can make a huge difference in their quality of life. And it's a relatively easy surgery to get over. All right. So this is my last slide. And again, it's important to understand arthritis to be able to do something about arthritis. Knowledge is power. And understanding that there are things you can do to improve pain and improve function. Again, pain is not a sign that you're causing damage. Flare-ups are not necessarily injuries. I mean, occasionally, people with arthritis can injure themselves too. It can happen. So again, if you suddenly go down and can't get up, that's a situation that you need to be checked for an injury to make sure nothing's broken. But beyond that, again, pain that gets worse 12 hours later, that's not an injury. Flare-ups can be prevented by consistency and activity. Exercise and weight loss have the greatest benefits. Exercise does not cause the arthritis to progress. Progression is not inevitable. And again, FDR, fear is the enemy. All right. Thank you all very much. Okay. So I'm going to have some time for questions here. I have the only microphone, so I may have to repeat the question for everybody to be able to hear it. But yes, sir, right there. Okay, so the question is about topical applications. And so what I would say is there are a lot of things that are over the counter that you might try, things that generally are going to feel hot when you put them on, or kind of those type of things. And they generally help maybe 20–25% of people. So they're not highly likely to help, but they're a reasonable thing to try, and some people do get benefit. There are compounds made out of capsaicin, chili pepper, what makes chili pepper spicy. Those, again, were really hot, no pun intended, in the 90s. The problem with those is the way they work, and what makes chili peppers spicy is they deplete something called substance P that's in the nerve endings that's involved with pain signal transmission. And so if you apply capsaicin to something regularly, 4 times a day, it keeps substance P gone, and over time it reduces pain. It actually makes pain worse for the first 3 or 4 days, and then once that chemical is gone, then that's when it makes pain better. The problem with it is, number one, you got to apply it 4 times a day for it to work. So if you're not religious about it, it's not effective. Number two is that also, as you get older, your skin gets more sensitive too. And so there are a number of people who developed bad chemical burns from capsaicin. So it's, again, something that's kind of fallen out of favor. There are topical anti-inflammatory medicines. In the United States, there's one prescription medication, diclofenac or Voltaren. It's pricey, so sometimes insurances will give you a lot of grief about it. It's not incredibly effective, but I do find it's a great option, and I do get some success with it in a number of people. Sometimes compounding pharmacies can make up other anti-inflammatory medicines as creams as well. And some people get some benefit from that. I'm not the hugest fan of compounding pharmacies. If you remember all the New England compounding pharmacy things in the news, I'm a little more cautious. But again, some people do get benefit from that. In senior living facilities, he's had experience with people that either like to exercise and do well, or people who can't tolerate exercise and do poorly. And specifically with some of the concerns about opioid medications, narcotic medications that I mentioned, and increased risk of falls, when is it a good idea to use those in that setting? A couple of comments to make. Number one, it is good that we're in San Diego. I've been here about 5 years, And compared to other places I live, one of the greatest joys that I have about practicing here, yeah, we can talk about the weather all day, but it's actually how willing people are to exercise here in San Diego versus other places that I've lived. And so I applaud all of you guys. You guys are much more active than other places I live. It makes my job a lot easier helping you. And so that's a wonderful thing about being here. But having said that, even here in San Diego, there are still people who struggle to exercise and who can't. So again, that's where the tools that I talked about help. And so typically I will start with injections, physical therapy, or topical medications as my preferred tools, and time, and talking to the patient on multiple episodes. Sometimes it takes me a little while to kind of get them over that motivation hump. And so I've seen people that 3 years later finally decided to start exercising, even though they had been pushing back for 3 years. And so not giving up is important. And again, there are some people that I will use mild opioid medications if need be, but again, it's really a last resort for me. But there are some patients that you need to use the last resorts because, again, not being active is bad too. But the key thing is also cautioning people about the risk of falls when they're taking those, and especially in a facility, observing people more carefully. Okay, yes? Okay, so the question is about what's the relationship between muscles and the joint and arthritis, and what are the relationship of bursa. So let's talk about muscles first. Muscles are actually extremely important. You're right. I talked for a very long time today, but there's some things I have to leave out for time constraints, and muscles are one of them, but they're part of the joint. And there is evidence to say that muscle weakness increases the likelihood of arthritis. It increases problems with pain and function. And it's a chicken or egg situation. If you have arthritis, you're more likely to not use the joint and then get weak muscles as a cause of it. So it goes both ways. Weak muscles increase the problem increases weak muscles. And so strengthening muscles can be very beneficial. So I talked about any kind of exercise can be beneficial, and that includes muscle strengthening exercises. And specifically, if we want to talk about arthritis under the kneecap, the patellofemoral joint. The patellofemoral joint is held in place by the thigh muscle, the quadricep muscle, and even a slight weakness in the thigh muscle lets that joint, lets the kneecap move around a lot. And if you have rugged cartilage underneath, there's a lot of stress and friction as a cause of that. So the absolute best treatment for people with arthritis under the kneecap is keeping the thigh muscle strong. So yes, keeping the muscle strong is important. The bursa, not so much. Bursa is a fluid sac under the muscle that helps cushion or lubricate it. And people definitely do get problems with bursitis. In my opinion, I think in particular in the knee, bursitis may be overly diagnosed and oftentimes not the major contributing factor. Shoulders are different stories. Oftentimes in shoulders, bursitis really is more of a problem. In the hips, it often can be a big problem. Pain on the side of the hip is typically not arthritis in etiology and usually is bursitis, although I could get off subject and talk for a long time. 60% of bursitis in the hip probably really isn't bursitis. It's a problem with the gluteal tendons where they attach to the hip, but the treatment's the same. So they can be important in some joints more than others. Okay, so the question is about sugar in the diet, and that sugar is inflammatory, and if you eliminate it from your diet, does that improve arthritis? Actually, the question asked is, should it improve arthritis? And the answer is, yeah, maybe. It should. Does it? We don't really have good data to know that at this point. Diet has been really complicated to get good scientific information, and I think in part because it's really complicated, that in different people, different diets have different effects. And if you try to look at a population of people, it's hard to ferret out that effect of different diets. If you look at a whole population, there really doesn't seem to be much benefit, but in certain individuals, there may be. So I think in this case, common sense applies. Actually, in everything, common sense applies. But again, eat a good, healthy diet. If you're eating a diet that's too high in sugar, that may be likely to cause problems. Now, one area, aside from diabetes, one area of arthritis where we clearly do see that is in gout. And specifically, high fructose corn syrup is actually a major, people talk about liver and shellfish and red meat. High fructose corn syrup may be worse than all of those. And again, so it's something that's very common in our diet in gout. So there are some studies that do show benefit, and by good studies, good placebo-controlled trials of acupuncture that show benefit for osteoarthritis of the knee or hip, for lower back pain. However, those same trials generally show, at least in a population of patients, that the effect size, how much better it makes people, is the same effect size that we see with acetaminophen or Tylenol. So the answer is yes, it can be helpful. The effect is usually modest. In some people, again, in a small percentage, it may be very helpful, but if we look at a large percentage, it's about as effective as Tylenol. So the question is, does sciatica have anything to do with joint pain? What sciatica means is a problem with the sciatic nerve, which is a large nerve coming out of the lower back going to the legs, and it can be pushed on by problems in the lower back or sometimes by muscles and cause pain in the legs. That's a great question. I'm so happy you asked that question. One of the things I do is I do a lot of teaching to students and residents and fellows in the clinic. And I will tell you, almost none of the time do the trainees think of back as a possible explanation for knee pain in particular or hip pain. I will tell you, in my practice, I can count, it usually takes more than one hand in 1 week to count the number of people I see who come to me with knee pain that it turns out to be their back that's the problem. It is actually very, very common to have a pinched nerve from the back cause pain in the knee. And so that's definitely something that I look for in my patients and try to ferret it out with the story. Typically, the pain tends to go down the leg, so pain that goes from the knee to the ankle, that's not likely to be coming from the knee. Usually knee pain will not go more than halfway down the shin, so if it goes all the way to the ankle, that's one thing that points me in the direction of the back. But also other things that people tell me, what I see on exam, what I can see on imaging studies. I've actually seen a patient recently who had knee replacement for what turned out to be a pinched nerve in their back. I have seen someone get a knee replacement for what turned out to be arthritis in their hip. So the question is several different things. One about topical lidocaine as a treatment for pain, and the other about another somewhat truth, somewhat snake oil industry in the mattress industry, and I can say that because in part it put me through medical school. My dad was in the foam rubber business. I'm allowed to comment on that. Talking about lidocaine, I do think that can be a good option. For some people with pain limited to a fairly small area in the knee, or we talked about bursitis in the hip or back pain, they can be a useful option. They're also an expensive option, so they can be a challenge getting insurance to pay for it. They're only FDA approved for post-shingles pain or diabetic neuropathy, so many times the insurance will balk on it. But talking about mattresses, yeah, they can make a difference on pain, especially with back problems, probably less so with hips and knees. But again, sleep is a period of long inactivity at night, and it can worsen problems, and sleeping on a bad surface can exacerbate pain. On the other hand, people spend gazillions of dollars changing their mattresses without getting better. So be careful about that. Try different options, and one, kind of good test might be sleeping on a different mattress for a while, but realize that that's not a good scientific study, because if, for instance, you're going on vacation, you're doing things differently than you were doing when you were at home, and those may be the factors that are doing into it too.